Hello friends, today we are going to discuss about attention deficit hyperactivity disorder in adults. I am Dr. Suresh Badadmat, Professor of Psychiatry working at NIMHANS, Bangalore. In this video, I'll be discussing about ADHD in adults, how to diagnose, how to do assessment and treatment of adult ADHD. Once ADHD was considered as a childhood disorder only, but at this point of time, scientific literature clearly says it is a lifetime diagnosis. That means ADHD continues to exist even in adults. Studies have clearly said that a child who has been diagnosed with ADHD will continue to have symptoms in adolescence up to 30 to 80%, and in adulthood up to 70%. That means 2/3 of the patients with ADHD will continue to have symptoms even in adults. Although ADHD was considered to be a childhood disorder, now the literature is pouring. That means it clearly says the symptoms continue to exist in adult. But however, there are some studies which clearly said that the ADHD the onset can be even in adult. That means they do not have symptoms either in the childhood or adolescence. The development may be after the 18 years. But however, these kinds of ADHD where the onset is in adult require systematic study, prospective studies, and neuroimaging studies has to be done. At this point of time, the literature regarding the adult onset ADHD is very minimal. But ADHD diagnosed in childhood continue to existing in adult is very common. Why this adult ADHD continues to exist? There are few important reasons. The main reason is the ADHD remains undiagnosed and undertreated even in childhood, adolescence, and even in adult. The main reason being stigma and discrimination. Not only stigma and discrimination, the access to treatment for medication, especially stimulant, is very minimal in developing countries. Not only that, access to psychosocial treatment, that is psychotherapy, that is also very limited. Above all this, awareness regarding ADHD is also minimal. Considering all these things, one more important challenge is we had a cognitive set that ADHD is only childhood disorder. Hence, even now, DSM-5 or ICD-11 puts a criteria that ADHD should be diagnosed before the age of 12 years. That means after 12 years, will it not come? That is the question we need to ask. We have this diagnostic criteria where we say ADHD should be diagnosed before 12 years. Does ADHD has read DSM-5 so that it will not come after 12 years? That's a scientific debate we will discuss in a different video. At this point of time, the current diagnostic criteria requires ADHD to be diagnosed before 12 years. Presence of comorbid conditions such as depression, ODD, personality disorder, conduct disorder, and various bipolar disorder, mood disorder adds to the challenge. And these diagnoses of comorbidity will mask ADHD. And of course, maturation of the brain during the age of 18 to 24 will decrease the hyperactivity symptoms. But however, inattention, impulsivity, emotional dysregulation continue to exist. Hence, because of the maturation of the brain, at the same time, compensatory mechanism in the brain takes over as the person becomes adult. Therefore, the DSM-5 and ICD-11 criteria have proposed to diagnose an adult ADHD, the minimum symptoms which required is 5 or more. Both, if you are diagnosing combined, that is inattention, 5 symptoms should be there. Hyperactivity or impulsivity, 5 symptoms should be there if you are making combined. Or if it is individual, 5 symptoms is required in each domain. Adult ADHD again has been classified into 3 types. Predominantly inattentive type, predominantly hyperactive or impulsive type, or combined type. It is similar to childhood ADHD. Let's discuss the DSM-5 diagnosis of adult ADHD. If you look at the ICD and ICD-11 or DSM-5, almost they are similar in nature. Both have 9 symptoms in inattentive and also hyperactivity domain. In childhood, the number of symptoms required is 6 or more, whereas in adult, 5 or more required in each domain to diagnose combined type of ADHD. And one more important criteria they have placed: the diagnosis should be done before the age of 12 years. That is the criteria, and what is the scientific basis, it is very difficult to discuss. Not only that, the symptom should be there at least in 2 or more settings, and also there should be considerable impairment in the activities. It may be in academic, job, social, or even in the home front and relationship issues. Let's discuss the symptoms of ADHD. As I mentioned, there are 18 classical symptoms. 9 symptoms pertaining to inattentive type, 9 pertaining to hyperactive and impulsive type. More than 5 symptoms is required in each domain. Onset should be before the 12 years of age. After 12 years of age, current diagnostic criteria do not allow you to make a diagnosis of adult ADHD. Diagnosing of ADHD in adult for the first time is very difficult because of the diagnostic criteria. Not only that, if a patient reports to you at the age of 20 and says he has difficulty in inattention, that means, as the diagnostic criteria says, you have to diagnose before the age of 12 years. That means retrospective analysis or retrospective getting the clinical presentation is very difficult. Although there are some scales are there, but it has its own merits and drawback. Above all these things, memory bias is one of the important things you should consider. Hence, the diagnosing adult ADHD first time in adult is a challenging, and the current diagnostic system will not allow. But however, if historically you are able to establish, you can make a diagnosis of adult ADHD. Let's look into the inattentive or inattention domain. There are 9 symptoms. Those are: fail to paying attention to details, makes careless mistakes in tasks and activities, that is 1. Difficulty in sustaining attention, does not appear to listen when spoken to, does not follow the instruction and fails to complete the task, difficulty in organizing tasks and activities, avoids or dislikes tasks required sustained attention, losing things need to complete the task, distracted easily or by extraneous stimuli, forgetful in daily activities. These are the 9 inattention type. Out of that, 5 is required for a period of 6 months to diagnose ADHD inattentive type. Let's look into the hyperactivity type. Again, there are 9 symptoms. It starts with fidgety and taps feet or hand, often leaves the seat when expected to be seated, runs around, climbs when it is inappropriate, has difficulty in engaging quietly in leisure activities, is continuously on the go and appears restless, talks excessively, talks over others, blurts out answers before a question is completed, has difficulty in waiting for his or her turn, interrupts or intrudes on others. Again here, 5 or more symptoms is required for a period of 6 months to diagnose ADHD hyperactivity domain or subtype. To diagnose combined type of it, both 5 symptoms should be present both in inattention type and in hyperactivity time. Let's discuss comorbidity in adult ADHD. As I mentioned in earlier videos, the childhood ADHD, the rule of thumb is comorbidity. 60 to 70% of childhood onset ADHD has comorbid psychiatric diagnosis. What happens in adulthood? In adult ADHD again, the comorbidity is very high. One of the important study done by Kessler and his colleagues, which was published in 2006, adult ADHD had high comorbidity. 40% of the adult ADHD had mood disorder, 50% had anxiety disorder, social phobia 30%, PTSD 12%, and 15% had substance use disorder. So, my dear friend, as the childhood ADHD continues to exist in adult ADHD, similarly, the comorbidity also continues to exist. Further, adult ADHD are twice as likely to be diagnosed with substance use disorder when compared to individual with ADHD. These comorbid conditions will complicate the things here. Invariably, adult patients will present with comorbid conditions such as substance use. When you take a temperamental history and personal history, the family member will definitely report that this person had a difficult childhood. He was very active. He could not finish his studies. He was on a constant go. That means you need to ask the presence of ADHD in almost all adult diagnostic category, because ADHD is a neurodevelopmental disorder. Similarly, schizophrenia, substance use, bipolar disorder have been considered as a neurodevelopmental disorder. Invariably, these are all comorbidities also with ADHD. That means even in adult ADHD, comorbidity is the rule. Hence, in all psychiatric cases which report to you, please check for ADHD. At the same time, when you are diagnosing ADHD, check for comorbidity. Hence, comorbidity is the rule both in childhood ADHD and also in adult ADHD. If you look at the translation of adult ADHD from childhood ADHD, you can see here. Usually, in ADHD in childhood, invariably it is seen as school failure and underachievement. Whereas in adult ADHD, unemployment, job failure, changing the job very frequently, or else getting removed from the job very easily. In ADHD in childhood, invariably that is multiple injuries. Whereas in adulthood, road traffic accidents, car injuries, vehicle injuries are common. In childhood, invariably substance experimentation or drug experimentation. Whereas in adult ADHD, drug dependence, alcohol dependence, tobacco dependence are very common. ODD and conduct disorder are seen in childhood ADHD, whereas in adult ADHD, invariably they will have antisocial personality disorder or else borderline personality traits or difficult personality. Invariably, conflict with law will be very common. ADHD in childhood will be seen as repetitive failure, whereas ADHD in adulthood will be seen as hopelessness, frustration, and becoming depressed, suicidal attempt, such attempts are common. Let's look into the adult ADHD and its impact. Adult ADHD and impact. Invariably, as in childhood ADHD, as they grow, their academic achievements will be very poor. School dropout and college dropout is very common. Hence, they will not be able to complete their academics. Invariably, they end up being incomplete in studies and joining or going to the job early, frequent job change. At the same time, because of this, their peer group also will changes. That means the kids who are good at academics, they move on. These children will be left behind. These children will get together, invariably will have interpersonal difficulties, gang activities, and if they have even interpersonal relationship, invariably they will be very difficult. That means they will be frequently changing partners, sexually transmitted diseases, AIDS, teen pregnancies, road traffic accidents, conflict with law, getting arrested, bodily injuries are very common. Further, as I mentioned, they will be unable to get the job. Even if they get the job, they will not be able to hold the job for longer duration. Relationship issues will be triggered by emotional dysregulation, impulsivity, physical violence, domestic violence, and frequent romantic relationship, and even stormy relationship, frequent change of partners, sexual transmitted diseases, and teen pregnancies are common. And these are all the impact of adult ADHD. Adult ADHD and crime. Studies have clearly indicated the crime rates are very high in adult ADHD. A meta-analysis comprising of 42 studies from 15 different countries indicated that adult ADHD was found higher in prison population. In youth, prison population, that is in adolescent and early adulthood, there was 5-fold increase in prevalence of adult ADHD. If you take adult prison population, there was 10-fold increase in adult ADHD in that population when compared to community prevalence. That means adult ADHD gets into law problems and they get arrested very easily. Now let's discuss about the prevalence. Prevalence of adult ADHD in community setting. Based on the pooled estimates and meta-analysis, 20 studies clearly indicated that prevalence is around 2 to 2.5% in adult ADHD. As I mentioned earlier, the childhood onset ADHD is around 5 to 7% in children and adolescent population, whereas in adult it is 2 to 2.5%. Let's look into the assessment of adult ADHD. One needs to be very thorough in assessment. The main reason being is, in adult ADHD, they do not come with the history of attention deficit hyperactivity disorder. Invariably, they are presented to OPD or in emergency department because of the comorbidities. Comorbidity because of substance use, bipolar disorder, personality disorder, impulsivity, suicidal attempt. These are the reasons they would have been presenting to you. You should not miss the assessment of ADHD in this case. ADHD is a neurodevelopmental disorder. Similarly, schizophrenia, bipolar disorder, substance use disorder are also considered as neurodevelopmental disorder. Invariably in adult ADHD, very few report with inattention or hyperactivity. Invariably, they present to you because of substance use or some other reason. Hence, you need to do a comprehensive assessment in adult ADHD. You cannot just do ADHD assessment because they do not present to you with ADHD symptoms. Hence, the gold standard is unstructured clinical assessment. That means you need to do a comprehensive, detailed history taking, clarification of history from the family members, parents, siblings, and other important members. It may be neighbors, it may be colleagues, wherever he has worked. You need to collect history from them. Before you do that, please do take consent. Please do look into the past history, medical history, childhood history, any history of consultation with psychiatrist, history of multiple presentation into emergencies, road traffic accidents, academic impairment, occupational impairment, financial instability, substance use, temperamental history, emotional dysregulation. These need to be checked. Treatment records need to be looked into it. Comorbid conditions need to be extensively evaluated. At the same time, when a patient with bipolar disorder or substance use or schizophrenia do present to you, check for ADHD in childhood. Clinical evaluation with mental status examination, observation should be done. Interview with all stakeholders is a must. Further, you may take assessment from structured instruments such as Connor's Adults ADHD Rating Scale, Adult ADHD Self-Reporting Scale, Brown's Attention Deficit Disorder Scale, Adult ADHD Clinical Diagnostic Scale, ADHD Rating Scale, ADHD Impact Module for Adults, Van der Remer Adult Attention Deficit Disorder Scale. These are structured assessment scale, but do not use it alone. These structured assessment scale should be augmented with clinical assessment. Without clinical assessment, these structured assessments are useless because they do not give you information. Invariably, adult ADHD presents with comorbidities, and they may present primarily for comorbidities, not for adult ADHD. Whenever you suspect adult ADHD with comorbid diagnosis, to diagnose this adult ADHD, these structured instruments may be useful. However, there are some open access scales, such as Adult ADHD Self-Report Scale by World Health Organization will assist you in diagnosing adult ADHD, or Van der Waals rating scale can be used. Other diagnostic interviews, such as structured diagnostic interview of ADHD in adults, semi-structured interview for ADHD in as an adult, are helpful. And these are open access scale. This can be used in your clinical settings. Again, I'll remind you, using structured assessment alone will not help you in making diagnosis of adult ADHD. A comprehensive clinical assessment is a must. Structured assessment will aid you in diagnosis of adult ADHD. Once you have made the diagnosis of adult ADHD, the treatment of ADHD is dependent upon severity of ADHD, presence of comorbidity, presence of substance use, presence of psychosis, patient preference, affordability, availability of treatment. All these will dictate treatment in ADHD. In treatment of adult ADHD, one need to consider multimodal, multidisciplinary, and multi-stakeholders approach. What is this multimodal? You need to combine psychoeducation, medications, if required non-stimulant medication, psychological treatment, social skills training, and coaching or mentoring is required. Multidisciplinary, involving psychiatrist, cognitive rehabilitation specialist, family therapist, behavioral therapist, yoga therapist, or else even coaching therapist may be required. Multi-stakeholders, patient, patient family members, patient partner, job supervisor, correctional center officers, and other important stakeholders need to be involved in the treatment of adult ADHD. Before you involve other people, please do take consent from the patient. Treatment of adult ADHD. Invariably, various guidelines, available literature indicates medication as the first line of treatment. In that, stimulants stand out with regard to available evidence, and non-stimulants like atomoxetine stand second. Psychological treatment, cognitive behavioral therapy, and behavioral therapy have been considered. Combination of both medication and psychological treatment, and finally, the coaching or mentoring also has been considered. I request the viewers to go through this important review article published in Therapeutic Advances in Psychopharmacology in 2018. This is a systematic review regarding treatment of adult ADHD, a clinical perspective, published by Geffen and Foster. This is an important article which you can read to know thoroughly about the treatment of adult ADHD. Treatment of adult ADHD falls into three categories. First one, childhood diagnosis of ADHD. That means the adult ADHD who is sitting in front of you for the treatment, he has already been diagnosed as childhood ADHD, and he continues to have symptoms in adolescent, and now he is presented again for further treatment, or else he is also on medication. What should be doing? What should be done with him? That is the first group. Second group, newly diagnosed adult ADHD. That means he was never diagnosed as ADHD in childhood or adolescent. First time he has come to you and you are finding that he may have adult ADHD. The third group, comorbid ADHD. Here the patient has presented to you for bipolar disorder, substance use, schizophrenia, or various other personality disorder. And you found that in childhood he had ADHD. What should be done? Let's discuss each one of them. Childhood diagnosed adult ADHD. That means in childhood he has been diagnosed with ADHD and he is on medication. What should be done? Please continue the same medication and therapy. Do not change. One need to consider changing this medication only if there is new comorbid condition emerges. It may be bipolar disorder, psychosis, or any other diagnosis like substance use disorder. You may consider drug holiday. Based on the patient preference, you can change the medication. Otherwise, please do continue the same medication. If the person has stopped medication, and he has poor compliance, first time he is reporting to you. In such a scenario, you can discuss with him, offer medication or cognitive behavioral therapy, or even combination of both. Based upon the symptom severity and his preference, the treatment can be chosen. The second one is newly diagnosed adult ADHD. He has never been diagnosed as childhood ADHD. First time he is presenting to you as an adult ADHD. What will you do? This is a very challenging task because neither DSM-5 or ICD-11 will give an opportunity for diagnosing adult ADHD after 12 years of age. That means now you have to do a thorough assessment to establish ADHD in childhood. And then once you make adult ADHD, based upon European consensus statement, the stimulants are the first line of treatment. That is methylphenidate or dexamphetamine. However, across most of the Europe, dexamphetamine has been found to be useful and has been approved for adult ADHD. The recent systematic review and network meta-analysis on the comparative efficacy of tolerability of medication for ADHD in children, adolescents, and adults, the first line of treatment is methylphenidate and amphetamine, even in adults. That means the treatment remains similar to children. However, the use of atomoxetine as a first line of treatment can be considered in certain cases, especially in substance use disorder. But however, some of the experts debate the first line of treatment should be stimulants. But however, many of them say atomoxetine should be the first line of treatment in adult ADHD. This is an ongoing debate. At this point of time, the literature and the evidence is increasing towards stimulants. Atomoxetine can be a good choice based upon the patient preference, based if the patient has anxiety symptoms, social anxiety disorder, psychosis, or bipolar disorder. In such a scenario, atomoxetine can be the choice. However, one need to be very careful. Once you start atomoxetine, you have to wait for a period of 2 to 3 weeks to get the action at the optimal. Stimulants acts very fast, whereas non-stimulants like atomoxetine requires time. There is a time lag that needs to be discussed with the patient. However, in certain cases, you can consider guanosine and clonidine. However, these drugs are very infrequently used in adult. There are conflicting results with regard to many medications such as bupropion, reboxetine, and modafinil. There are few open label trials with regard to this. At this point of time, stimulants or non-stimulants such as atomoxetine remains the drug of choice. Moving to the third, comorbid ADHD. Here, the patient has presented to you with bipolar disorder, substance use, or psychosis. During the treatment process or during the personal history, you come to know the patient had childhood ADHD and continues to have symptoms. What will you do at this point of time? Here, the choice of treatment first will be the comorbid bipolar disorder, comorbid psychosis, or comorbid substance use disorder takes the priority over adult ADHD. Hence, you need to treat the bipolar disorder first. Later, you can consider treating the ADHD. And you need to remember the risk factors which are involved in comorbidities. The risk of possible drug-drug interaction with comorbid medication and ADHD should be considered and dealt very carefully. If a person with bipolar disorder and ADHD is there, stimulants can switch the patient to mania. In such a scenario, you need to give stimulants under the cover of mood stabilizers, or else please consider atomoxetine along with mood stabilizers. Moving to the substance use disorder and ADHD. A large Danish registry study showed a decrease of substance use in ADHD patient when using methylphenidate. The recommendation is to use long-acting, higher dose, avoid short-acting stimulants. That means some of the studies do not contraindicate methylphenidate or stimulants in substance use disorder. The consensus statement mentions that use of stimulants treatment in ADHD does not precipitate the onset of SUD in adult patient. That means you need not be apprehensive that by giving methylphenidate, you may induce SUD in adult ADHD. Further, ADHD and pregnancy. Invariably, the studies are very less. Whatever available literature, case reports with regard to stimulants and pregnancy, there are few case reports which clearly indicate there is no increased risk of congenital malformation using stimulants. However, we need to be very cautious because we do not have a robust data. Methylphenidate and atomoxetine might increase the risk of miscarriage, that is abortion. The risk of cardiac malformation was found to be slightly high in patients who are using methylphenidate. Hence, you need to warn the patient if she is on methylphenidate and she becomes pregnant. Looking into adult ADHD and postpartum. MPH, that is methylphenidate, seems to be very safe during breastfeeding because these stimulants are less secreted in the breast milk. The amount of medication secreted in the breast milk is very negligible. And again, after consumption in the infant, the serum level of methylphenidate is very low. But however, studies are very less. And if you require to give stimulants in breastfeeding mother, methylphenidate can be considered. But however, please do keep an eye on mood symptoms because postpartum depression, postpartum psychosis can be precipitated in methylphenidate. But however, you need to be very watchful, regular follow-up, and regular clinical examination is essential. Now let's move into psychosocial treatment. First and the foremost, psychoeducation of the patient and family members is a gold standard. Without psychoeducation, many of the adult ADHD will refuse to take medication. Invariably, they think that they are very active, they may have certain difficulties in attention, and they may refuse medication. Both patient partner, or the family members. Hence, psychoeducation, giving literature about ADHD, and other materials is very essential. CBT can be considered, but however, CBT is best used with multimodal treatment approach. That means combination of medication and CBT is very helpful. Using cognitive behavioral therapy alone may not be useful to many extent. Further, coaching can be considered. There is a study which was published in 2020 by Fullan and his colleagues. The title of the study is Psychological Treatment in Adult ADHD, a Systematic Review. In this systematic review, 53 papers were identified and included in the review. 92% of the studies found significant positive effect either on primary or secondary outcomes associated with adult ADHD. The strongest empirical support derived from cognitive behavioral therapy intervention. In addition, findings indicated support for effectiveness of mindfulness, dialectical behavioral therapy, and neurofeedback. That means cognitive behavioral therapy has been found to be useful in ADHD. Similarly, one more important systematic review was published in 2020 by Smith and his colleagues. This was published in Psychological Medicine. In this systematic review, 32 eligible studies were included, and majority of the evidence indicated towards cognitive behavioral therapy. That means cognitive behavioral therapy was useful in adult ADHD. However, in this review, they also suggested preliminary evidence indicates towards improvement by using mindfulness, cognitive remediation, dialectical behavioral therapy, and hypnotherapy. However, evidence for these is very weak. That means these are open label trial. The homogeneity of the study is not there. The intake criteria and also the preliminary outcome and blinding of the assessor is very poor. Hence, the methodology is questionable. hence a systematic study of prospective in nature is required. One more important study published in Journal of Attention Disorder in 2020 by Eng and his colleagues with regard to systematic review and meta-analysis of randomized controlled trial was published. In this, there were 9 RCTs were taken into consideration and 2 subsequent meta-analyses were considered. In the first one, 4 trials, total n is equal to 160. They compared CBT with waiting list. In this, CBT was found to be very effective in adult ADHD with a moderate effect size. In a second group, 3 RCTs were considered and n is equal to 191 subjects. Here, CBT was compared with the active control groups, maybe behavioral therapy, exercise, and various other active treatment were considered. Again, CBT was found to be effective in small to moderate effect size. That means CBT has a role in adult ADHD. Further, the largest controlled multi-centered CBT study to date had demonstrated the psychosocial intervention results in better outcome when combined with methylphenidate or stimulant when compared to psychological intervention alone. That means combination of treatment plays a very important role, and this has been published in JAMA. In a systematic review of 51 pharmacological and non-pharmacological intervention, the highest proportion of improvement was noted in combination of treatment in adult ADHD. So my dear friends, whenever you choose to treat an adult ADHD, please recommend the combination of medication and psychological treatment. ADHD symptoms may not improve to some extent, but however, they have been found to be very useful with regard to coaching in certain outcome aspects. The coaching and mentoring have been found to be useful in reducing the avoidance behavior, reducing learned helplessness, reduced self-efficacy can be decreased, procrastination can be addressed, depressive symptoms and anxiety symptoms can be helped by coaching. Most coaching and mentoring programs are skill-based, organizational-based, time management skills, emotional dysregulation can be managed, pro-social competency can be enhanced. That means you may not treat the ADHD functional improvement directly, but by enhancing the pro-social behavior, social skills behavior, interpersonal skills, time management, motivation skills will be helpful in coaching. What will happen if you don't treat? What is the impact of untreated ADHD? In untreated ADHD, there is a poor quality of life, poor relationship, poor family support, marital discord, divorce, reduced employment, vulnerability for addiction, substance use, depression, anxiety, teen pregnancy, increased sexual transmitted diseases, multiple partners, conflict with law, getting arrested, injuries, road traffic accident, suicide, deliberate self-harm, and premature death. To conclude, my dear friends, ADHD is a neurodevelopmental disorder and a lifetime disorder. It is no more a childhood disorder. ADHD is a combination of genetics and environmental factors. Here, multi-genes are involved and multi-environmental stressors play a role in precipitating ADHD, maintaining ADHD, and course and outcome. Most of the time, adult ADHD remains undiagnosed, untreated. Most of the cases which report to the hospital are because of comorbid condition. Hence, the clinician need to be very careful when you are treating the comorbid conditions such as bipolar disorder, substance use disorder, schizophrenia. Please do ask for adult ADHD as a comorbid condition. Hence, early identification and treatment is crucial in the outcome of ADHD. 2/3 of the children who have been diagnosed with ADHD continues to have ADHD in the adulthood. Again, in adulthood, medications are the first line of treatment and stimulants have been found to be very useful. Physician need not be scared about that you are going to precipitate substance use disorder in adults. The evidences are against it. Again, combination of treatment is very essential in the outcome of adult ADHD. And please remember, treatment of adult ADHD again is lifelong. Hence, prepare the patient, family members, and patient partner for a long battle against adult ADHD and comorbid condition. Thank you very much for your valuable time. Stay safe.